Hello, everybody. Namaste. A big thank you to Indian Arthroscopy Association for organizing these small lectures. I am Dr. Abheek, and I'm an orthopedic surgeon attached to Apollo Clinicals Hospital, Kolkata. And regenerative medicine is one of my areas of interest, and cartilage replacement is part of that. And I'm going to share in the next couple of minutes some case scenarios and a very basic overview of cartilage replacement or cartilage transplant. Cartilage replacement has been going for a couple of years or rather a couple of decades. It has progressed a lot. So I'll straight away go to this case. He is a physician, 39-year-old physician, and he's been complaining of gradual onset knee pain for the last 6 months. And the pain has been increasing so much so that his ADL is restricted. He walks to his clinic, and he's been complaining of pain even in the night times, and he has problems climbing stairs. And the interesting clinical finding was we would expect the medial joint line to be tender in such cases, but his medial femoral condyle had a specific tender spot there, and which was extremely painful there. And there was a mild crepitus there. The X-rays were unremarkable, as you can see. There's nothing much to talk about the X-rays, but MRI which showed this particular defect there. As you can see, there's a probably a 2 centimeter defect there right at the medial femoral condyle. And as you can see, the defect is there's complete loss of cartilage there. And there is surrounding bone edema as we would expect. The exact cause, we're not sure what the exact cause is like. So when we don't know the cause, we classify it as idiopathic. And we know that osteochondritis dissecans usually happens at a slightly younger age group. And before we plan any surgical procedure, one of those things which we have learned is to get a full length X-rays to look for any malalignment issues, because we know a malaligned knee and a cartilage replacement don't go together. And one of the failures is due to one of the malaligned knees there. So we discussed the treatment options with the patient, and we still continue treating many of these patients with rehabilitation and nutraceuticals for many reasons. Many of them don't want any procedures. They're happy to pop in some pills and some powders, and we know how much they work. And another procedure which has been going on for many, many years is the microfracture technique. The problem with microfracture is that although it's a simple, small procedure, is that the fibrocartilage is not as strong as the native hyaline cartilage. And that's where cartilage replacement surgery has been successful, because it gives you hyaline-like cartilage. The word I use is like, because you can never have the original hyaline cartilage there, but it is almost as strong as the hyaline cartilage. So the patient here, the doctor, he readily agreed for the procedure, and we went ahead with that. It is actually a two-stage procedure. The first part is harvesting the cartilage, and it is just like harvesting a skin graft. But this is a procedure where we use an arthroscope. We use a harvesting technique to harvest from these areas, the edges of the condyles, the intercondylar notch, and the small piece of cartilage is actually put into a test tube in a controlled environment. We send it to a laboratory where they will actually use specialized tissue culture, cell culture techniques in India, and multiply these cartilage cells into huge numbers. And after 3 or 4 weeks, it is sent back to the hospital again in the controlled environment, and we operate on these. It's a second stage. This procedure requires an admission for a day or two. So the first procedure was a daycare arthroscopy, a simple arthroscopic procedure which anybody can do. And as you see, this is the arthroscopic picture there. There's a huge defect there. I did not find any loose body there because this cartilage piece would somewhere there, but I could not find any loose body there. One of the things which is very important, that this particular thing should be left alone like that. Don't try to scrape it, shave it, or puncture holes into it. Because if you do a microfracture technique now, the results are not as good. So try to just come out with the piece of cartilage there. The size was 2 centimeter, 1 centimeter here. As you can see, it matched the MRI findings there. And this is the device, a simple device which is made here in India to harvest the cartilage there. The key here is you identify the area where you want to harvest the cartilage from, and these are the areas. And from the condyles, you need to go at least around till this mark, around 7 to 8 there, so that you can take a piece of cartilage, and also you can take a piece of the underlying cancellous bone, which is important so that the cartilage is preserved there. You just can't take a piece of the cartilage out there. This is another key step in harvesting. We need to tap this piece out gently, because we don't want to break that piece of bone coming out and into splinters, because the whole piece of cartilage is attached to that bone, the underlying bone, and that is very important. So once this thing comes out, you can see the gentle taps I'm making, and you ask your assistant to hold it, because you don't want to drop it on the floor. And once this piece comes out, you gently have to just put it without crushing it into this box. This box has got an inner container and an outer container, and it has got these fluid which maintains the pH level at the same level as the body, and some preservatives there. We put it back into the second box, and we put it in a 2 to 8 degrees controlled temperature environment. We have to courier it back to the laboratory within 72 hours. The process of culture should have start before 72 hours. That's important. Otherwise, the cut is going to die there. So this is what happens in the laboratory. I'm not going to share details of how it is cultured, but this is what they do. They somehow harvest around and multiply the cartilage into 48 million chondrocytes, huge numbers, 48 million. And it is supplied along with some fibrin glue in these bottles. And each bottle has around 12 million cells there. So I'm told that you can transplant huge areas, multiple areas, femur, tibia, patella, femur. So different areas you can do multiple transplants at one go there. The procedure is very simple actually. There's no rocket science in this. You do a simple arthrotomy of the knee. You expose the medial side of the knee. We actually can expose the whole of the femoral condyle by this exposure. It's a simple exposure which we all do in TKR procedures there. And when you open up, you will see this big defect actually has an overlying fibrocartilage. And you'll be wondering that why do I have to do a procedure? But if you just scrape it, and you'll see it comes off very easily. And once it comes off, you'll see this big defect there, underlying there. So I'll show you the slide where how we do the scraping. Scraping involves two ways. One is using a knife, and second a curette. The process of applying the cartilage is very simple. There are two syringes, a Diplojet syringe there. One will have the cell, another will have the fibrin. There is a combination of mixing that. And once we press, the both mix together in a liquid form, and we start from one end and we gradually go to the other end. And at this particular juncture, you have to keep your defect size horizontal to the ground, so that if you tilt it, the chance of the cartilage falling down either this way or that way. So you make sure that it is absolutely horizontal there when you are injecting. It's like glue. It's just like Fevicol. It's not like water. So this is why I want to mention. I'll spend some extra time here in this slide. Now the process of scraping involves, when we start scraping, you will see this, the floor has got some fibrocartilage and some yellowish bone there. So the edge needs to be nicely cut with a knife. With a knife, you need to nicely cut and make it as sharp as possible. And then the process of curette starts. The curette will happen so that you will undermine the edges like this. So there's a beveled edge like that. So when the actual glue goes in, the fibrin glue and the cartilage, it goes into these corners and nicely gets stuck there. Also, we need to make holes at the subchondral area with a 1 millimeter drill bit. This 1 millimeter drill bit, if you don't have 1 millimeter drill bit, take a K wire, 1 millimeter K wire, and the holes, the number of holes depend on your square area. So you have to make 3 or 4 holes per square centimeter area. So make those holes adequately spaced. Don't go too deep so that the gel goes just inside there and locks there. And this is where the cartilage cell with the fibrin will go and lock in there. Once you have done that, now you have to wait for it to set. So 3 to 5 minutes of setting time is adequate. And don't poke your glove finger there and to see how it is going. That is the time. You don't need to do anything. Just let it set. And once you have done it, you have to move the knee a couple of times in flexion extension for that to take the shape of the the underlying tibia condyle there. And once you've done that, you just need to close the wound. No drains are required. In this particular case, it's a simple procedure. The follow-up physiotherapy is again very simple. If you have a tibial condyle or a femoral condyle lesion, then you can start gradual bending of the knee in 24 to 48 hours. You have to achieve somewhere around 90 degrees of flexion by 3 weeks and around 120 degrees of flexion by 6 weeks. And simple quadriceps exercises will do. You need to do partial weight bearing from 2 to 4 weeks onwards, strengthening exercises, and back to sports probably at 8 to 12 weeks there. But if you have a patellar lesion, then you need to go slow. Probably after 2 to 3 weeks, you will start exercising, and gradually we again have the same regime there. This is the MRI of the gentleman at 6 months. As you can see the complete loss of bone, edema there, it's gone. You're gonna see near normal cartilage there, right there. And you will not see any scarring there exactly there. So I'll show you some more examples of how they look this is his clinical outcome. As you can see, no malalignment there in the knees, and his pain just disappeared, and he's absolutely fine. These are a couple of cases I would like to show. Defect there and defect after that. You don't need to do routine arthroscopic procedures post-operatively to see. These are initial couple of cases where we were all curious how the cartilage looked like, and patients consented for a secondary look surgery there. Another case, 38-year-old male, 8 square centimeter defect. Again, you can see a near normal hyaline cartilage there. 28-year-old male, 4 square centimeters defect, again normal. I have not done a single case of osteoarthritis yet, but I'm aware that some cases have been done for osteoarthritis there. So to summarize, this is right now the best treatment for cartilage loss. And these are 4th generation gel based. Initially, during our MS days, we would read about putting cartilage cells under periosteal patches and how we had to stitch those by 6-0-ethylone, keep the patches there. And it was a cumbersome procedure. So this is just a fibrin glue which goes and sticks there. The other area where it can be used is osteochondrite dissecans, especially in grade 3 or 4 when it has almost come off. And cartilage injury athletes, it's a big procedure for them. The reason is most of these patients would want to get it done towards the end of the season, and because it takes a long time for them to rehab, around 6 to 8 months. So we usually do them towards the end of the season so they can be fit for the next season. And younger patients do much better than older patients. We know the reason is simple. The regeneration capacity is much better. And like I said, in osteoarthritis and inflammatory conditions, I have never done a case, and I sincerely doubt whether that it's going to be successful. It's a simple, reproducible technique. Anybody can do it. But I would suggest that please read the manual, the simple steps of harvesting, and just go and do it. It's a simple procedure. Thank you very much. I hope you guys liked the lecture session on cartilage transplant. And please let us know how your first case was. Thank you very much. Bye-bye.